So again, my name is Amanda Bose. I'm a manager here with NASTAD's Healthcare Access team, and I'm also joined here by Laura Pegram, who's a senior manager for drug user health. Our state presenters from Utah include Brianne Glenn and Heather Bush. And then from Virginia, we are also joined by Diana Jordan and Kristen Donovan. So in terms of our goals and objectives for today's webinars, first and foremost, we want to be sure that we are increasing understanding around sort of what are the intersections between injection drug use and HIV, as well as other comorbid conditions, including those that are infectious diseases such as hepatitis, including hepatitis C. We also want to be sure to give you all a sense of sort of what are the specific needs for people who inject drugs who are living with HIV in terms of services, et cetera, and some of the structural barriers they face. We also want to lay the groundwork in terms of the federal funding landscape for SSPs, including specifically what is undergirded by the HRSA-HAB, as well as other federal local policies that might influence or impact how SSPs are funded in your jurisdictions. We also wanted to highlight sort of the unique aspects of the HIV care continuum and the impacts that are for people who inject drugs who are living with HIV. And then lastly, we wanted to provide some recommendations from us here at NASTAD, but also from your peers in terms of their experiences in leveraging Ryan White Part B program funds and ADAPs to collaborate with SSPs to benefit people who are living with HIV who inject drugs. So now I will pass the baton to Laura to provide us with an overview of all of the infectious disease implications, et cetera.
Great, thanks, Amanda. So hi everyone, welcome today. I've been asked and tasked with kind of going over sort of the intersections of infectious disease and injection drug use overall, sort of a history of funding both state and federal for syringe services programs, and then also just kind of lay the framework about why it's so complicated and how we have to be really creative in our use of different types of funds, both federal, state, foundation, local, whatever donation you can possibly get. Yeah, so just so that we're all on the same sort of page and jumping point, right? So we know that injection drug use accounts for about 9% of all new HIV cases and about 65% at least of hepatitis C cases in America, right? Among people who inject drugs, about 7% are estimated to be living with HIV. And we know that only about 57% of those report having been tested within the past 12 months. So we're clearly missing a big category of folks here, a big blanket of folks, right? We know that rates of linkage to care, retention in care, and viral load suppression are low. In terms of hepatitis, 60 to 90% of folks who are injecting drugs have hepatitis after 5 years. Each year, about 20 to 30% of those folks injecting drugs acquire a new case of hepatitis, and you're bound, your median time to actually acquiring hepatitis is about 3 years. We know that comorbidity is really, really high with HIV and hepatitis, so this is a thing that needs to be addressed within our programs, that among people who inject drugs who are living with HIV, 75% also have hepatitis C, and as a comparative number there, we know that people who are living with HIV without injection drug use behavior, only about 25% have hepatitis, right? And you guys know more than anyone that this stuff is really expensive, that the lifetime cost of care for HIV is about $400,000, with each infection, and that the accumulated cost of care for hepatitis C treatment in America, if we continue on our current treatment trajectory, is over $78 billion. We also know that there's a lot of other things that are associated, corollary conditions associated with injection drug use behavior. So we have the hepatitises, I can't even say hepatiti, the hepatiti, HIV, also bacterial infections and soft tissue infections, the bacteremia, septicemia, abscesses, endocarditis. All of this stuff can be really incredibly expensive. In fact, a study came out of Florida just this last year that estimated that the cost of running one syringe access program, about $200,000 per year, is equivalent to public treatment of 6 bacterial infections related to injection drug use, just 6. Right, so in terms of people who inject drugs who are living with HIV, we know that there's a lot of historical and current barriers to care, right? The majority, 81%, have incomes at or below the federal poverty level. In the past 12 months, 56% report having experienced homelessness, 24% have been incarcerated, and 16% have been uninsured. So we know that this is a, termed as a sort of hard to reach population, but also like our services just aren't quite getting to folks. And obviously this is, something to do with stigma and something to do with just access to care in general. But we are tasked with a pretty big task here. So just in terms of increases in terms of hepatitis C and also injection drug use behavior in America, there was a study put out about a year and a half ago that basically saw from 2004 to 2014 about a 400% increase in acute hepatitis C among very young folks, 18 to 29 years old, with an equivalent about 700% increase in treatment for admissions for injection of either opioids or heroin together. And those numbers are just a little bit lower for the folks right above that. But really, we're seeing super sharp increases overall in this group, right? And I bring in Scott County, and I was, it was a question of whether we should even bring it in. But the reason I bring in Scott County is that this was the largest HIV outbreak and hepatitis outbreak related to injection drug use in America. So Scott County, Indiana is a county about 24,000 people. Austin, Indiana is 4,200. This outbreak occurred in 2015. And right now we're at about 232 cases of HIV were eventually attributed to injection drug use behavior. And if you see the little dog chew toy thing here on your right, that's actually the EPI investigation. So if you could zoom in on all that gray area, those are distinct lines. Those are distinct transmission points or shared transmission points among this very small community. In the past decade, before identifying the initial, I think it was 45 folks, right? In the past decade, only 5 cases of reported HIV had occurred. So it's, this is just, we throw it out there because this really changed a lot of the national dialogue around the need to increase funding and support for syringe services programs more broadly. And it really kind of was the impetus for where we're at now with federal funding. So after Scott County, the CDC came in and they ran this study looking at 7 different distinct social determinants of health related to what made Scott County just so vulnerable, what made it just so vulnerable to this type of kind of explosive extreme outbreak. And then they overlaid those 7 variables across the country. And so that's what we see here. All these green areas are the top 220 counties in America that are the most vulnerable to an outbreak similar to the one experienced in Scott County. And now you'll notice some things here, right? I started doing harm reduction work in New Orleans and I was like, New Orleans is not on here, New York is not on here, Seattle is not on here. And the reason is that what they were measuring, one of the protective factors was in fact that access to drug user health services and syringe access programs was already a protective factor. And there are some other, clear issues in terms of why certain places showed up and why others didn't. Also, these are just counties that are vulnerable to a very specific type of outbreak like that in Scott County. So keep that in mind. But SSPs was actually one of the big takeaways, right? We know full well in the literature that SSPs are the most effective way to prevent infectious disease transmission among people who inject drugs, that they do not increase drug use or crime for individuals, and that participants who access SSP services are actually 5 times more likely than non-participants to eventually enter into treatment and 3.5 times as likely to decrease their injection behavior. So really important tools. And like I said, Scott County kind of was the impetus here for changing a lot of those, our approach to funding them in general. So we know that that there's a real range of programs. SSP programs can be everything from mobile backpack outreach, a van, to a storefront, to clinic-based, and that they're all really important and all save lives. In terms of HIV-specific prevention, there are several studies that indicate that the 4 main things that we really need to have on board to make that the most effective intervention is access to medication-assisted treatment, HIV and hepatitis screening and treatment on site, HIV pre-exposure prophylaxis, and behavioral health services. And then, I think it's really important also to think a little bit more broadly about how we approach drug use in America, because also all too often, even when Scott County happened, we have this, well, we have an opioid crisis, an opioid epidemic, and what do we do about it? Well, lots of people will say we should just prevent people from using drugs and we should just treat them. And it sets up this binary, this misunderstanding about what all happens between when someone starts using drugs and when someone might actually need treatment. And we see in numbers that actually a lot of people don't actually even need treatment to necessarily, mitigate their behavior, their injection drug use behavior or drug use behavior. So, so I think that really the focus here is thinking about what happens between this prevention and treatment binary. And there's a big range there, and just some real quick numbers just to give you a sense of scale, because that's where harm reduction and syringe services programs really play in here, right? So according to the 2016 SAMHSA National Survey on Drug Use and Health, approximately 10% of the US population used drugs in the last month, and that includes marijuana. Over the last year, about 12 million people older than 12 used prescription painkillers or heroin. In that same data, only 2.4 million people met criteria for having an opiate use disorder. So if you think about that 12 million and 2.4 million, right, our gray area there between prevention and treatment, it means that about 80%, 9.4 million folks, right, are using opioids, and they don't even meet the diagnostic criteria for treatment, right? Meaning that they're arguably, a majority of our services need to fall in this center part, into the harm reduction realm of things. And we see what this, could potentially look like here. We need hepatitis, HIV treatment, access to mental health services, medication-assisted treatment, PrEP for people who use drugs, safer injecting practices to prevent those soft tissue infections and abscesses, things like that. And obviously, naloxone, overdose prevention, there's really, that's probably the most important overall. So on to funding. We're laying the ground here. So on to funding. So over the last 30 years, nobody has ever wanted to fund syringe access programs on a federal level. So the past 30 years, there's basically been a ban on SSP federal funding that's existed with a few short lapses here and there pretty consistently. Like I said, in response to the Scott County outbreak, the appropriations cycle in 2016 incorporated language to allow for limited use of federal funds, limited use of federal funds specific to certain specific items that we'll get into in a minute. And this kind of opened up a whole realm of opportunity, but also complication, and maybe unnecessary complication. So here we have the language that basically, like I said, permits the use of federal funds from DHHS or CDC, actually any federal funds, to be used towards SSPs, right? So in order to do so, there are a few things that you have to have in order, right? So you have to have what's known as a determination of need, which I'm going to go into in a little bit, which basically is the CDC agreeing with you that yes, you are at risk for or experiencing an outbreak of HIV or hepatitis related to injection drug use. You need to have a local ordinance that allows for syringe services programs to operate. And that could be either state or local, it's fine. And then also you need to talk to your project officer, and that will be your project officer either through HRSA or CDC, right? Here's our language. And you guys are going to get this slide, so I'm not going to read it for you. But the real takeaway is that you have to have those things in line before you can start using federal funds, meaning that you have to have a determination of need, and that basically indicates that the CDC concurs you're experiencing or at risk for an outbreak. And in terms of what the CDC, in terms of what is fundable or not, what it really comes down to is that direct injection equipment, which has been basically put out there as, you can use federal funds to support any aspect of a syringe services program in your jurisdiction if it's legal, and then you can't use the federal funds to purchase the actual syringes or the actual cookers, the metallic little caps that you will actually cook drugs in. Everything else is fair game. But it's not quite as easy as that. When we think back to the different range of services and things that could live within an SSP or could live in conjunction with an SSP as referral sources, that it really is just, it's not quite that easy. And especially when we think about all the different federal agencies that could be funding those services. So we included here a flowchart basically from the AIDS United put this out a few years ago, talking about the different sort of process, like the process for what it takes to get a determination of need. And, so we'll just leave that here for your reference. And just as a note, NASDAQ and myself helps with this stuff all the time. So if you're one of the jurisdictions that does not have one, please reach out. I'm here. But fortunately, the majority do have it. 37 states and territories currently have a determination of need on the books, which is great. and several in distinct counties and parts of different states have one as well. And like I said, in order to get to comprehensive services, we have to have a really complicated level of coordination in terms of the different federal agencies and the different types of services. So here's somewhat of a complicated service coordination structure, right? So ideally, we'd have an integrated strategy right at the top. Right now, we don't really have that at a federal level, and and I think that we're trying to piece that together, and that's a big push for us in general. But really, what we see is that that integrated strategy, in theory, would be that everyone pools their money and figures out where along that continuum in terms of the services, right? We need to fund certain services and have them present for people who use drugs. So the integrated strategy would indicate who are the federal funders, and the big ones right now: CDC, SAMHSA, HRSA, foundations. These bigger, the VA can fund this. And then that money all kind of goes down into state agencies. And you guys know how this works, right? There are federal allocations, they go to your state, the state divvies them up and they separate them out, and you figure out which ones you can provide to different agencies, and then that actually goes down into the actual agencies and the drug user health services. And what it ends up looking like is that we create a system where at the bottom here in the agencies and service providers, and also at the state agency level, we're left to kind of piece together all these different federal funding streams and state level funding streams in order to provide adequate services within our CBOs, within our SSPs, and that's just really, really complicated. And Ryan White is a big, big part of that, and we're hoping will be an increasingly large part of that. But part of that complication is really what has led to part of the reason that we just decided to do this project in general. So often what ends up with services at the state level and at the agency level is that we have to figure out how to braid this funding. We have to braid together your Medicaid funding, your SAMHSA funding, your single state agencies, all your HIV and hepatitis programs. It's not like they have money anyway, but who knows? And and then that really ends up just being a real challenge for both states and agencies to figure out. So some potential partners and potential funders in terms of where we could look for these big buckets of money to come from is, like I said, HIV, infectious disease, hepatitis, injury and overdose prevention have to be there in terms of SSPs. Single state agencies, that SAMHSA money is much, much larger than a lot of the infectious disease money. So ideally we'll have partnerships there. And then obviously substance use prevention programs and what we're here today to talk about, HIV and chronic care services. So I'm going to pass it over to Amanda, who's going to go into that part.
Thanks so much, Laura. So as part of today's presentation, we're really going to focus just on those allowable core medical and support services within the Ryan White Part B program. And for those of note, those are really only allowable for those people who inject drugs who are living with HIV already, with the exception of one, which we'll go into more detail on, which is the early intervention services. So as many of you are aware, we included it in the memo before this webinar, and it's also available as a handout in this platform, if I figured out how to use the technology properly, a fact sheet that Laura and I developed that specifically lays out a lot of what we've discussed today, as well as service-specific information, and we highlight those that we think make the most sense to consider funding using Ryan White Part B funds in combination with an SSP. So for a full detailed rundown of sort of what is allowable under each of those service categories, we would encourage you, if you don't already know it, to review the HRSA Policy Clarification Notice, PCN 1602. And then here on this list is sort of the running list of those services that are all featured in that fact sheet, and we'll focus in on a few specific ones today to lay the groundwork for our state presentations. So first, we want to talk about specifically under Part A and Part B, early intervention services, which we will feature in our state presentation. So for those who aren't familiar, early intervention services is intended with the goal of assisting and identifying those individuals who are either out of care or who don't know their HIV status, testing them, and then linking and re-engaging them into care and referring them for necessary care and treatment services. So with that in mind, there are 4 components to EIS that have to be available at any subrecipient that's funded to provide EIS. So that includes targeted HIV testing and referral for HIV care and treatment, referral services to support and other care services that help to promote or improve HIV care and treatment outcomes. So maybe those that relate to adherence, housing, retention, case management, et cetera. Third, access and linkage directly to HIV care and treatment services. And fourth, outreach services and health education risk reduction, specifically related to HIV diagnosis. So of note, as I said, all of these four components need to be in place and available at facilities, or I'm sorry, at recipients that are funded to provide them. However, any individual client doesn't need to necessarily receive all four components under EIS. And so the reason why we wanted to highlight this is that obviously when you're talking about targeted HIV testing, et cetera, and especially hitting or serving as a complement to other prevention and testing efforts, it makes a lot of sense to consider people who inject drugs and who are using services at SSPs as a population that would really benefit from EIS services. And a lot of those, especially testing and referral for care, are things that are already occurring, as Laura mentioned quite a bit, at SSPs. So we really see this as an opportunity to sort of scale up or enhance those services using Ryan White funding. And I just also wanted to mention that for a lot of folks, or when I say folks, I mean jurisdictions, have also leveraged EIS as part of their overall data to care activities and platforms in terms of linking and re-engaging clients as they find them to be out of care. So it can be part of sort of broader efforts, not just the service delivery itself. So next we wanted to highlight substance use outpatient care. We do also under Ryan White have residential care, but we wanted to focus on outpatient care because that seemed most relevant to SSPs. So what it includes is screening and diagnosis and assessment for drug or alcohol use disorders, as well as actual treatment for substance use, including MAT. So obviously, we've talked quite a bit about how MAT in particular for people living with HIV have huge treatment outcome improvements that are possible, including in terms of viral suppression and also treatment adherence, et cetera. And SSPs quite frequently are either co-located with substance use treatment, or at the very least, they have very strong referral systems in place to direct people to those services elsewhere if necessary. So I also wanted to highlight the health education risk reduction service category separate from EIS. So while you can fund health education risk reduction in combination as part of EIS, you can also fund it separately if, for example, you're talking about an SSP or a subrecipient agency that maybe isn't equipped to do robust testing or all of the four components. You can fund this separately and apart. But what it specifically covers is in terms of providing clients or those living with HIV information on sort of what does it mean to be living with HIV, but also ways to reduce the risk of transmission to others. And similarly, like these are services that are very commonly already occurring in SSPs and can be scaled up even further with Ryan White funds. This is sort of a new one that maybe folks haven't considered before, but we did want to highlight medical transportation, which under Ryan White includes the provision of non-emergency transportation that allows clients to stay in or be retained in care, so to make it to visits for either core medical or support services. And the ways that it really makes sense is in terms of like SSPs, especially if you're talking about the provision of MAT and other substance use treatment and using medical transportation to ensure that you're covering their transportation to those visits so that they stay in care, and then obviously from there, as a result, are more likely to stay adherent to HIV treatment medications, et cetera, and to see improved health outcomes as it relates to HIV. Non-medical case management is another service category that is oftentimes already sort of funded or in existence at SSPs in terms of referring clients to necessary services and helping them to navigate a very complex system of care and to address various structural barriers they're experiencing. And so, again, this is something that is already in existence and that we think that funding can be used to sort of bolster in terms of the amount of staff, to reduce caseload, for other opportunities to really expand on case management. And outreach, similar to health education risk reduction, can be funded sort of separately from EIS, but it does include sort of identifying or finding those folks who are either who are living with HIV but don't know their status or are in need of being re-engaged or linked back into care. But it must be conducted among or within places in which there's a high probability that individuals are either infected with HIV and or they're engaging in behaviors that could risk their, or that it could increase their risk. And again, this can also be a part of data to care and also be combined with HIV, but also hepatitis, as some jurisdictions have in the past. And then lastly, in terms of service categories, we just wanted to highlight the general category of referral for healthcare and support services, which includes sort of directing clients to necessary other Ryan White services that they may benefit from, and is another example of something that SSPs are frequently doing and could scale up and expand with additional support from Ryan White Part B programs. So separately from the service category conversation, we do get a lot of questions related to administrative cost. So as Laura mentioned, SSPs, because of challenges in terms of acquiring sustained funding and a whole host of other reasons, they operate at times with very sort of like low infrastructure and low capacity, shoestring budgets, et cetera, as Laura said, in my ear whispered. And so we wanted to highlight this because, these are really critical providers that maybe could benefit from additional funds to really bolster their capacity and infrastructure in a way that they haven't historically been able to do so. So one of note, especially for folks who are less familiar with Ryan White and the legislation, is that the legislation only allows for a very limited amount of the total aggregate grant award for the Part B program in this case, or the Part A, but we focus on Part B today, to be used to cover the cost for administrative. So it's 10% of the aggregate cost across the entire Part B program, and all their subrecipients can be used for various administrative costs, and it's up to 15 if it includes administration, planning and evaluation. And then there's also a separate 5% or 3 million, whichever the lesser of the two, cap for clinical quality management. But again, that's aggregate, that's across all agencies, et cetera. And that applies specifically to federal funding. So those caps aren't in place for when we're talking about rebates or state funding that might have been allocated to these programs. And so some of the ways that we wanted to highlight that these funds could be beneficial for SSPs is, for example, you can cover the cost of staff. So for example, if you're considering creating a role within your health department of somebody who would really work closely with SSPs and other drug user health programs, that could be a position that could be key, that could be funded by somebody and dedicated. Also, as I mentioned, infrastructure generally can be limited. And this especially shows up when we're talking about the maintenance of data systems and things like that are helpful for any recipient or subrecipient that you may be funding to provide data back to you for purposes of the RSR, et cetera. I'm not going to get too far into it, but there is space for very minor, minor alterations or renovations. We do provide more detailed specifications on what that can include, but that can include equipment, et cetera, as well as minor changes to the actual facilities themselves to enhance their ability to see clients. And it has to obviously benefit a reasonable amount of people who are living with HIV. And then lastly, there is space to also increase capacity overall through trainings for staff either within SSPs or with health department staff who will be collaborating with SSPs, whether it's around cultural competency around people who inject drugs or use drugs who use services at SSPs, or in terms of trauma-informed approaches, which we won't spend as much time with, but trauma is certainly something that plays a huge role in terms of the care and outcomes of people who use drugs, including those who inject drugs. So very quickly, I just want to conclude with a few recommendations from us here at NASTAD. So one is we do want to make sure that people are aware of and really understand that there are a whole host of comorbidities and other social and structural barriers that really challenge people who inject drugs, including those living with HIV, in accessing and continuously staying engaged in healthcare and supportive services. And that SSPs are a very well-tested and effective provider for services to people who inject drugs in a non-judgmental and really evidence-based way. And that can be really supported and further strengthened by collaborating with Ryan White programs and funding. And so we would therefore encourage Ryan White Part B programs to consider ways that they could, in theory at least, or in practice, strengthen those partnerships that they have in place with SSPs, and consider ways in which they can consider sort of funding more services within SSPs or more activities that are allowable into the program in these areas. So with that, I will pass the baton now to our speakers from Utah, including Brianne Glenn, who is the Part B manager, and Heather Bush, the Syringe Exchange Program Coordinator. So Brianne and Heather, can you all hear us? I think we can hear you. Perfect. All right, so go ahead.
Great. We'll go ahead and go to those first few slides. There are basic slides that we have for about the Department of Health. So Brianna and I will kind of be going back and forth a little bit because we have different pieces on this. Since I'm coming at it from the prevention and syringe exchange side, she'll be coming at it from the Ryan White and policy side, which is a really great balance. So go ahead and move forward next and next. Okay, so a little bit about our overview here in Utah. So our HIV testing previous to implementing EIS through our SSPs, a lot of acronyms there, was that we did about 5,000 publicly funded tests per year, and that was mostly through our local health departments and a few CBOs who are contractors of ours through the HIV prevention grant, and most of that focused on MSM. So a lot of the local health departments was, walk-in and general public, but a lot of the outreach and through our CBOs was really focused on MSM. PWIDs were largely overlooked or not targeted just because of the limited resources and the few organizations that we had focusing. Do you want to, well, I'll talk about this part, Brianne. So the Ryan White Part B, what we decided to do is we started looking at the EIS money, and we realized that we didn't have any other funding for SSPs available here in Utah. We don't have any state HIV hepatitis funding. And so we started looking at how we could leverage some of our Ryan White funding because we had a lot more, as was talked about earlier, looking at ways we could start braiding some of the funding in. We were using a little bit of HIV prevention funding to support administrative staff here at the health department, but to go directly to the SSPs, we started looking at this EIS model, which Brianna will talk about a little bit more in a moment, but it was really a good opportunity to work more with that PWID population that hadn't really been reached before, and was a good way to try to identify people who were actively using, who may also have HIV, and to get them tested and linked to care. Next. So this is a lot of text, I realize, but I just wanted to give you guys a brief timeline and kind of an overview of how this happened. So our syringe exchange law went into law 3 years ago in May 2016. It kind of caught us by surprise, unlike many other states that have been planning, having programming, maybe even doing lobbying to try to get a syringe exchange law passed. Ours was passed pretty quietly and then kind of dumped in our lap. So the law says that the Department of Health needs to administer it. So it got dumped on the Department of Health lap and then dumped in my lap, which I was happy to take, but it was kind of a surprise and we had to do some scrambling. I was working in hepatitis prevention at the time. So the first thing we did was submit our determination of need, like Laura was talking about earlier, which allowed us to start moving some of the HIV prevention funds to cover my salary and some other administrative costs that the law did not provide any sort of funding to do. And there's a slight typo in there. This was my fault. I didn't catch it till earlier. But in July 2016 is when we were able to start funding my position, as well as working a little bit with our prescription drug overdose program and our violence and injury program here at the health department to get a little bit of in-kind support. They helped us with some training and technical support. Through this time, we developed an administrative rule and had it published, as well as developing a web-based database. So all this, again, is basically with HIV prevention funding. And then we started enrolling agencies with our first agency doing syringe exchange in December of 2016. That went on for about 7 months we had 3 to 4 agencies who started doing syringe exchange, but it was all with their own funding. The only support that came from us was a little bit of training. We were able to allocate some state funds to purchase syringes, but otherwise they were on their own. So again, this is where we started looking at what can we do to help fund them more directly. So in April of 2017, we released a request for proposal for EIS funds for SSPs. We funded 5 organizations with EIS funds. 4 of them were directly involved with syringe exchange. And that was in July of 2017. So we started with that fiscal year. The second, which went really great, we learned a lot of lessons, which we'll talk about a little later. But then our second year, we did some adjustments. We looked at the performance and compliance with all of the EIS components by our contractors, and we did some adjustments. Some of them were just not able to adapt and do what needed to be done in order to fulfill the EIS requirements, and we didn't want to compromise the funding in general, so we made some adjustments with our contractors. And then we made adjustments again just this past March, and we were able to receive some SAMHSA funding, so therefore we were able to move some of those contractors on to more of the SAMHSA funding, and then freeing up the EIS funding to be more specifically for those who were able to comply with all the requirements. Next.
All right. Good afternoon, everyone. This is Brianne Glenn. I am the Ryan White Part B Policy and Eligibility Manager. So like Heather mentioned, back in April 2017, we released an RFP. It was not just specific to EIS services, but it had several other service categories in it. So agencies could apply for standalone health education risk reduction, or they could apply for all 4. So right here on this slide is just a screen grab of the HRSA PCN 1602. Amanda did a great job going over this earlier, but the one piece that I wanted to highlight is the targeted HIV testing. So there's HIV testing paid for by EIS, cannot supplant testing efforts paid for by other sources, which is really, really important as we continue to move along. So if you have not read this part of the PCN, I encourage you all to read through that. There's some really good information there. And could you move to the next one? Next slide, Amanda. Thank you. All right, so some policy consideration. So as it was mentioned earlier, so EIS is the combination of 4 services, including elements of other service categories. So I would read each service category very carefully, and the 4 are outreach, health education risk reduction, referral services, and also HIV testing, which did not get included there. Okay, so all 4 components of EIS need to be available to create an EIS program. So we reached out to HRSA to get clarification on this, and what we were advised was that not all services need to be provided in the same encounter or even by the same provider. So as a Part B program or what other Ryan White program you're using to fund EIS, you just need to ensure that all 4 components of EIS are available within your EIS program. So if you have an agency that is solely doing testing and outreach, you have other agencies that are doing the education and referral, it just needs to have a comprehensive flow through the components to qualify as an EIS program. So one other thing, very, very important lesson learned, is that EIS is not an HIV prevention program. So earlier on, there was that chart that was displayed that went from the testing to harm reduction to treatment. So just kind of keeping that gradient in mind. So EIS is more on the harm reduction to the treatment end of that spectrum. The intent is to identify and enroll someone living with HIV into Ryan White services. So the intent is not to prevent HIV necessarily, and it's not to have those prevention messages be the primary focus of an EIS program. So one thing to be considering as you're moving forward with SSPs is what is the intent, experience, and focus of your SSP. If they are focused on prevention, then a lot of education support should be provided to that provider to ensure that they understand EIS and how that fits within their structure. One specific example is the word outreach. So outreach means something completely different if you're on the prevention side or treatment side. So if you're in prevention, outreach may be going out to the clubs or the bars or finding individuals who might be injecting drugs, and it's a kind of like a group conversation. It could be done anonymously. Through EIS and through Ryan White, outreach cannot be done anonymously. And so that's something that Heather will get into a little bit more in detail. But you need to be able to provide the lens and context of EIS, which can be a little bit of a shift for your SSPs. And also determining if an encounter qualifies as an EIS encounter or a prevention encounter. And a lot of that can be intent, what services are provided during that encounter, and what information is being provided as a result of that encounter as well. Okay, next slide, please. All right, very important. So the support, not supplant. So if you're going to start funding SSPs or with EIS funds, specifically with HIV testing or referral services, if those things are currently being funded, how is funding these services with EIS dollars or Ryan White dollars, how is that going to impact where the other funding is going? Are you adding additional services? Are you hoping to shift prevention dollars or state dollars to other services? All of that needs to be thought through and documented as well. And how are you going to coordinate testing efforts with your HIV prevention program? So here in Utah, the Prevention, Treatment, and Care Program, which houses the Ryan White program, as well as syringe exchange, previously hepatitis prevention, STD prevention, HIV prevention, and surveillance is all integrated. So we're all an integrated team, and a lot of our funding can be braided and is a little bit more organic. If that is not the case in your jurisdiction, you may want to reach out to your prevention counterparts and bring them on board while you are planning your EIS program and reaching out to your SSPs to see how this might impact different funding and contracts out in the community. And again, so documenting funding allocations and redistributions may be different in your jurisdiction or state, but adding additional services, especially with syringe exchange being a new service, having it be a little bit political hotspot, we were very cautious of ensuring that we documented all of our funding decisions, as well as any changes in funding sources and what that went to, as well as being very, very great at documenting what those dollars went to, such as they did not go to purchase syringes, they did not go to purchase cookers, making sure your contracts, support that, and just having that very clear so that you can provide that information to funders, legislators, and anyone else who might be interested in your work. All right, so eligibility. So EIS clients generally are people who are not confirmed HIV positive, so they are at risk or they don't know their status, but it's targeted testing, and it's targeted towards individuals who are at high risk, who may need to be tested and then linked and referred to Ryan White or other HIV services. So you need to look at what are your state's Ryan White eligibility requirements, and also for example, how are you going to verify residency? How are you going to ensure that services are provided to the appropriate populations, and all of those details, and Heather will get into what that really looks like on the ground. Other considerations, what documentation are you going to require? Are you going to require SSPs to conduct an eligibility screen for EIS clients before providing syringe exchange services? Are you going to have them submit reports or case notes, or what other information are you going to be collecting? And also, where is your funding coming from? So if you are funding EIS with your Ryan White grant dollars, then you will need to be reporting on your Ryan White Services Report or your RSR. So how are you going to get the information from your SSPs to do that? If you're funding with rebates, currently that's not a requirement to report on the RSR, but that very likely will be changing. So all of these considerations, as well as, if you're going to apply, national monitoring standards and subrecipient requirements to your SSPs, all of that will need to be considered as you are moving forward with funding SSPs with Ryan White dollars. Next.
Okay, great. So as Brianne said, all of those things we had to consider as we were putting together our RFP, and some of those are things that we kind of learned along the way and got clarification from HRSA on as we went along. But a lot of my job then was, how do I translate this to our SSPs? As we know, our SSPs are often very grassroots. They maybe don't have a lot of experience with working with these really strict restrictions, working within, HRSA and maybe even CDC requirements. So my job was to try to translate that to them, and then especially the clients of SSPs are even more obviously removed from this. So since EIS funding requires that the clients cannot be anonymous, we had to gather names. Previously, when we were doing this without EIS funding, they could just enroll anonymously, but once we funded our agencies with EIS funding, they had to have a name, and they had to show that they were, in our case, Utah residents, because we couldn't serve anybody who wasn't a Utah resident. And as Brianne mentioned, you have to kind of decide how you're going to do that. So we use the same residency documentation that our Ryan White Part B program does, which is fairly flexible, but it also can be really challenging for people, especially if they're experiencing homelessness, or they're extremely mobile or extremely chaotic, or maybe just out of jail or prison, things like that. So that was a little bit challenging. And then they may have legal issues or concerns, so they may not want to give up their information or their ID. Those are things that we considered. We lucked out that we've had actually very little problems with that. People have actually been very willing to participate, but it has still been a bit of a thing to get over, and made things a little more complicated, because we do check every single person and every single encounter to make sure that it fits all those requirements. And that was part of our data collection. So then we had to create a database to both fulfill the needs of the law, of the EIS requirements, but also still be flexible and workable with the SSPs and the clients. We didn't want it to be too cumbersome for them, but at the same time, we wanted to make sure we were getting everything we needed so that there would be no question that that EIS money was being used properly, which required a lot of training, consistency. We've also had to do a lot of monitoring, ensuring that all those requirements are met, again, with every single encounter. And that required a lot of reviewing billings and doing quality assurance exercises to make sure that everybody fulfilled all the requirements that they needed as far as eligibility, residency, that the activities were appropriate and they fit under that funding. So you may think that that sounds like more trouble than it's worth. It was a little trouble getting it started and getting people to wrap their head around it, but eventually it became just fine. It's part of our routine. And now, even though some of our agencies have moved away to less EIS funding, and one of them completely away from EIS funding, they're still keeping a lot of these in place because they were actually really good standards. So it hasn't been as challenging as we thought it would be, but it was difficult a little bit to get it started and to ensure that consistency. And then it helped us be able to, we had some concerns on that if every single encounter had to involve testing, or at least the option for testing, that's a little challenging in some of our outreach settings with SSPs. As Laura mentioned, it could be, with a backpack in a park. Obviously, that's not going to work. So they had to arrange their the actual exchange activities to be conducive to doing all the EIS requirements, which included HIV testing, which with the rapid testing makes it much easier, but it still has certain standards. You have to maintain temperature, you have to maintain confidentiality, those types of things. Next slide. So like I said, we've learned a lot of lessons about that, as Brianne mentioned, that all SSPs have to have all the elements of an EIS program, and they may not have capacity to do so, so that can be a challenge. Go ahead.
So my recommendation from a Part B EIS perspective is to outline or design your EIS program for what you want that to look like in your jurisdiction, and then see how your SSP can fit within that framework rather than the other way around, because we really started with our SSPs and then tried to fit EIS into those SSPs as they were standalone, which worked. It absolutely can work. There's some challenges, a little bit, sometimes a struggle to make it fit, but it did, and it definitely made SSPs possible within our jurisdiction and got us through until we do have other funding sources today. But if you do have a different option and a different path to take, I would recommend do the opposite of what we did.
Yeah, that's a really great piece. So to look at that EIS service as a component of SSP, which is instead of the way that we did, which we tried to really fit the square peg into a round hole, and that wasn't working so well. We also learned a lot more about the benefits of identifying those people with HIV within syringe services and being able to get them tied into treatment and care. And it really helped us reach more people who were not being reached before with HIV services. And then, like I said, we've also learned to switch it to different fundings like the SOR funding from SAMHSA to make it a little more comprehensive, but still have that EIS component, and to keep it as a way to really focus in on those EIS elements rather than, again, trying to make it fit into all the SSP requirements. So we've kind of balanced, it's taken us 2 years, but we think we've kind of got it figured out to where those, that EIS funding is really helpful instead of a hindrance. And it's really, I think, made our services much more comprehensive and much more high quality. And that only helps with legitimacy when SSPs are always a controversial item. Anything that we can do to add legitimacy, and our efforts have really helped with that.
Mm-hmm. And I'll just add one more lesson learned that didn't make it to this list, is how valuable SSPs are as a community partner, regardless if you're able to fund them or not. Having them on your planning groups, having them as part of your committees can be invaluable, as they do have a different dynamic with some difficult to reach populations and individuals who are at high risk for HIV, and also may be requiring different services out in the community. So that's been extremely helpful in our planning processes to have our SSPs more engaged with the state level.
It helps them understand it better and helps the other partners know them better, and kind of welcome them into the fold. Next slide. And that's it for us.
All right, thanks so much, Brianne and Heather. We haven't seen any questions come through the chat that we can see, but we will let you know at the end if we do see some come through. Otherwise, oh, what a transition. We will switch things over and welcome Diana Jordan, who's the Director of Division of Disease Prevention in Virginia, as well as Kristen Donovan, who's a Health Policy Analyst. So Diana and Kristen, can you hear us?
Yes, can you hear us?
Yep, perfect.
Okay. So we're going to walk you through Virginia's process for funding syringe services, and I'll warn you, we call it comprehensive harm reduction, so I'll be slipping that in throughout the presentation. So, but what I plan to do today is leave you with some strategies that should be adaptable to any locality. Next slide, please. So this timeline starts from the point where comprehensive harm reduction in Virginia started to pick up steam. So in late 2016, just before the Thanksgiving holiday, State Health Commissioner Marissa Levine declared Virginia's opioid addiction crisis a public health emergency. So the following year, during the first week of the General Assembly in January 2017, Delegate John O'Bannon introduced House Bill 2317, which would allow syringe exchange and broader harm reduction efforts during a public health emergency, which had already been declared. So in late February of 2017, that bill had passed both houses and was signed into law by our governor. That law went into effect on July 1st of that year. So it's important to note that Delegate O'Bannon had introduced a similar bill during the 2016 GA session, which failed. And this failed bill had amendments to the criminal code, which would allow people accessing syringe services to do so without fear of paraphernalia or possession charges. So the GA isn't in session throughout the calendar year here in Virginia, so if a bill doesn't pass during those early months of each year, the next opportunity is the following year. July of 2018, so a year after the law went into effect, the first comprehensive harm reduction site opened in Wise County, and currently Virginia has 3 sites operating, and 6 jurisdictions are working toward opening a site. Next slide. So here you see the indicators that VDH used to find localities at greatest need for harm reduction, comprehensive harm reduction. CDC had already released their assessment of communities at risk for a southeastern Indiana type outbreak, and as you saw earlier, the assessment included several counties in far southwest Virginia. But harm associated with injecting drugs occurs across the Commonwealth, so VDH compiled these data from stakeholders to compare risks in different localities. This slide is an overview of the data we looked at when and who we got it from. So next slide. Covering this very briefly, so if you have questions on this, you can contact me or Diana if you'd like more information about how we evaluated localities. So we analyzed the data, plugged it into a scoring rubric, and deemed the locality scoring above the state average eligible, so 75 eligible localities. Next slide. So here you see the distribution by locality with those eligible in blue. As expected, the localities flagged by CDC as at risk were eligible by the VDH criteria as well, and you can see those identified by localities circled in red. Oh, it barely shows up. Okay. Maybe that was missing, but if you look toward Appalachia, so the far, far, far side, those were the counties that CDC deemed eligible. Okay, next slide. So let's take a step back in the next few slides and define comprehensive harm reduction in Virginia. So these images show a CHR staff member here in Richmond and materials distributed by our first site in Wise County. It's important to note that these materials were distributed by Wise for years before the syringe exchange was even possible. So they've been working on harm reduction for quite a while. Next slide. Next slide, please.
Sorry, let me try go back and forth. We're on a typical exchange encounter, that slide?
I don't see that. Okay, there it is. Okay.
Okay, sorry.
All right, so we're going to walk through what a participant would experience at a CHR site. So if you were a client at one of Virginia's sites, on your first visit, you'd be issued a participant card to show in the event that you encounter the police on the way to or from the CHR site. And as I mentioned earlier, Virginia Code does not currently protect participants from paraphernalia charges. So you would have to trust that the law enforcement in your locality would use their discretion and not charge you if they stop you on your way to or from the site. So in your first visit, you'd be offered HIV and hepatitis testing, and if you accepted that, the staff would offer you follow-up testing quarterly. You'd also be screened for basic needs, food, clothing, shelter, things like that. Women would be screened for pregnancy, and you'd be offered appropriate referrals, including substance abuse disorder counseling. So if you brought syringes to your first visit, you would tell your CHR worker how many you brought and put your sharps container, detergent bottle, Mountain Dew bottle into the collection bin. You'd be offered a sharps container and or instructions on safely stowing your used syringes. And finally, you'd get sterile syringes and other supplies as needed. Next slide. So Wise County, again, Virginia's first site, is part of the Lenawisco Health District. As you see from this slide, their harm reduction efforts preceded their official designation as a CHR site by years. Their consistent effort to reduce harm associated with injecting drugs and their existing partnerships in that effort paved the way for them to get their program up and running quickly. So let's run through how they paid for those efforts. So syringe cleaning pamphlets and supplies, those came from local monies and 1802 prevention money. Enhanced testing for hepatitis and HIV, that came from state, local, and 1802 funding. The post-exposure treatment for hepatitis B exposure was local funding. PrEP and NPEP was state, not something that's Ryan White eligible. Revive training, this is our naloxone administration trainers training, was not Ryan White eligible, but it was provided in kind by another state entity. And Narcan, providing the drug itself, was a combination of local, state, and SAMHSA funding. Next slide, please. Okay.
Hi, Kristen.
So,
Oh, go ahead.
that's a slide that I happen to be missing here. Oh, there it is. Okay, in my notes too. So with funding for comprehensive harm reduction limited and highly restricted, BDH had to get creative. So as our state funds are the most flexible funding stream, we wanted to free up as much of that funding as possible. And to that end, Virginia works to get people living with HIV enrolled in health insurance. So providing medication through insurance is about half the cost of directly purchasing them. In order to use the federal funds for allowable comprehensive harm reduction costs, we submitted a determination of need and discussed plans with HRSA and CDC project officers. Next slide. Okay. I have a different order here. So, all right. So this is a visual representation of funds that comprehensive for harm reduction in Virginia. And your locality, I'm sure, will have some differences, but the process should be similar. So look at your funding streams and look at the restrictions. And to the degree you can, you divert costs covered by your most flexible funding streams to more restrictive funding streams, if that's possible. So the money that you move over, you can use that money to fund tricky to fund line items like syringes. Next slide. All right, on to the braiding. I should have had a lovely braiding image. I love that earlier. So here's how we pay for comprehensive harm reduction. Using rebates and CDC prevention funding towards staff, travel, supplies, and then one of our state partners, the Virginia Department of Behavioral Health and Developmental Services, provided SAMHSA opioid grant funds to BDH to refurbish existing vehicles and purchase new ones for mobile comprehensive harm reduction services. For syringes and anything else not allowed on federal grants, we use private funds, and we can dip into this bucket when our viral hepatitis testing needs extend beyond federal funding. We use state funds to support PrEP and hepatitis C treatment, which are not permitted on current federal grants. And so, bottom line, if you're looking for ways to fund your comprehensive harm reduction program, consider what you want to fund, see whether you have a funding stream that could cover that cost, and see what you can move away from your most flexible funding sources into a different funding source to free those funds for comprehensive harm reduction. Next slide, please. Okay, so Virginia is making good progress, and there's still a lot of work to be done. Lack of protections for participants against paraphernalia and possession laws are a huge barrier to participation in localities with a comprehensive harm reduction program. And currently there are 6 localities in Virginia in the application process, and most of these are being delayed by a lack of police support. And ironically, perhaps police chiefs cite the same gap in the criminal code as the barriers to supporting comprehensive harm reduction. That's their primary job, is to uphold the code of Virginia. So if they're they're having to ignore the code, then they feel like they're not doing their job. So our hope is that the next General Assembly session, legislators grant the same protections to participants that staff enjoy at our sites, and that should fast track these new sites. So the 2017 bill included a sunset clause to expire in July 1st, 2020, and in order to get enough data to evaluate effectiveness, we need the GA to extend this sunset clause as well. So that's really all I've got, and I want to give a shout out to our dedicated staff and community partners, because without them there would be no comprehensive harm reduction in Virginia. So I thank them for their hard work and assistance in compiling these slides. And that's it. Thank you.
Thanks so much to you both. And so in terms of where we will go from here, we've allowed plenty of time for some Q&A. So I first will begin by taking a look at our queue that has been accumulating throughout. So we do have a couple. So first is, since EIS is to find HIV cases, how often is HIV testing offered to SSP clients? Can the client still get supplies if they decline testing? So I may need some additional clarity, which you can add in terms of the chat function to make sure that we are responding to the exact questions. So in terms of how often HIV testing is offered to SSP clients, we don't have any aggregate data across all states in terms of, you know, how many jurisdictions are even funding EIS among SSPs, and among those, how many clients. I will note that EIS is a little bit funny overall in terms of the reporting, because for the purposes of the RSR, you're only expected as a Ryan White program to report clients who are certain of that who are HIV positive. And so it's up to the jurisdictions to find other ways to quantify how many people who were tested who turned out to be negative. And so some jurisdictions have done different ways and different data systems to capture that. So I don't think that we would have that data necessarily reliably. I'm not sure if if Brianne or Heather, if you all have some anecdotal evidence from Utah to specify, but if not, you know, that's something that we can circle back on. And then the second question, which is in terms of how clients can get supplies if they decline testing. So you're either using EIS or you aren't. You can be served through you can receive other services that the SSP may be offering, but it's not going to be EIS. EIS, you have to offer sort of all of that, and that test, and really like the 4 components, much of which are contingent on somebody actually getting an HIV test and being found to have tested positive. So in terms of supplies, if you're speaking about sort of injection-related supplies, that can't be funded through EIS anyway, so that would be private funding, and obviously you could still fund it. I don't know, Laura, if there's anything else you would add.
Yeah, and I think I'm reading this question a little bit differently. So,
okay.
So one of the 4 components of EIS
Yes.
is the opportunity or the availability of testing, not necessarily that the testing has to happen at every, right? The EIS funds the testing itself, right, but not the services.
Yes.
You know, and so for an SSP to be eligible to gain EIS, you know, status or whatever, I don't know what the word of that would be, you know, it just is that they have to have that capacity on site or indirect referral.
Yes, I mean, that is my understanding, especially from Utah's experience as well, from seeking additional clarification from HRSA, is that all 4 components need to be present and accounted for in terms of the overall EIS program. Although you can have them located at different sites, you do need to have like clean flow of clients to be able to move from one facility to another to receive all the 4 components. And you can also offer like outreach and referrals as a separate component from testing too, or from EIS.
Hi, this is Heather from Utah. I can kind of answer those questions together.
Sure.
Basically what you said, what we did is that we have it in our contract that every EIS service, HIV testing has to be available and offered. So they have to have basically their rapid testing set up and available and all the supplies, and then they have to offer it to every single client. If the client refuses, and it could be because they maybe had a test recently or whatever, or we've had cases where people refuse it every time for months, and then they come in and say, now I want an HIV test. But they have to at least be offered it, and it has to be there and available so that they can do it. That's the requirement in our contract. But then we record, as a part of that, we record that they refused it. We record why they refused it, and then if they do take it, we record that as well. So we have the record of their refusals, all negative test results, and then obviously all positive test results. So we have that on a jurisdictional level. I recognize that that's not equivalent across the country, but so that's how we make sure that that's all recorded so that we can indicate, yes, this was offered, they refused it, and this is why, or they accepted it, and this is what their result was.
Thanks so much, Heather. We have another question that I think is EIS specific, and you may all want to chime in as well. It is, does an existing program already funded that wants to add an additional site count as quote unquote supporting and not quote unquote supplanting? So I'll start by saying, so when we talk about supporting versus supplanting, that's about existing prevention efforts. So if prevention is already funding testing and you're basically switching out prevention funding for Ryan White funding, unless otherwise approved on a case-by-case basis, that generally is not the goal and isn't allowable. So if you're adding an additional site that isn't otherwise receiving testing related dollars, then that's fine. Then you're not supplanting, you're just supporting or expanding the capacity for that. Heather, or Brianne, is there anything else you would add for that?
No, I would agree with that statement. I think in our jurisdiction, we are just mindful of funding, and even that could be a year or two down the line. So if we add Ryan White dollars to an activity, and then a year later we're looking at reducing funding through our HIV prevention, those are things you need to keep in mind as well.
Perfect. All right, thanks so much. And we did also have someone chime in through the chat, Holly from Iowa, to affirm Laura's comments. So thank you, Holly. If there are no other questions or clarifying ones, I should say, in the chat, we do have a poll for all of the participants. So first, we will start with if your jurisdiction has funded Ryan White Part B services or allowable activities within standalone or integrated SSP settings, and you select one, sort of yes, no, or unknown or unsure. And so we'll give folks just a few minutes to start to respond. All right, so the majority of people are saying either no or unknown or unsure. So if you are saying yes, if you wouldn't mind sort of in the chat giving us a sense of sort of what are the kinds of services or activities that you're funding already, and just a quick description is great, just so we can get a sense. As you may all imagine, there aren't so many overwhelming numbers of jurisdictions who are doing this. So if you are and we weren't aware of it, we'd love to be able to, to follow up and to learn more about sort of how that's working and to connect peers as necessary. Okay, so it looks like things are stable at about 23% yes, that they are funding services in standalone or integrated SSPs, 46% say no, and about 31% say no or unsure. So I'm going to close that poll. I'm just going to expand the chat just to see if anyone has chimed in. Okay, I'll give folks a minute. And if you also would feel more comfortable, following up by email after the fact. Speaking of email, we're going to correct Laura's. That was a typo on my part on the front. So we'll be able to reach out to us with correct information. Otherwise, we will start a second poll. So for those of you who have not actually provided services or funded through SSPs, have you considered doing so at some point, sort of yes, no, or again, unknown, unsure? Okay, so as things are working their way, it looks like that there are a few no's, but the vast majority have either said yes, they've at least considered it, and about 50% have actually said unknown or unsure, and that might be reflective of sort of who's on the line. Oh, we actually have, okay, so we do have a comment from someone who has actually provided services, it looks like, under Ryan White. So they have an agency that provided HIV testing that started a new SSP, and we provided about $13,000 in funding spread over 2 RSR years, or Ryan White Services Report for those who aren't as Ryan White familiar, to purchase supplies such as syringe disposal bags, a locked storage cabinet for supplies, and an iPad to provide client education. So thanks so much. If I haven't captured who actually asked that in the jurisdiction, we will follow up and be sure that we get your information, because that is a new anecdote that we weren't aware of. Right. Okay, so returning to our poll. So as I mentioned, about 41% said that yes, they had at least considered funding these services. 15% said no, and 44 were unknown or unsure. So for those who have at least considered it, what, if any, resources or assistance would be helpful to receive either from us here at NASTAD directly or from some of the peers, either ones featured today or others that we are aware of, to help you to sort of move from consider to actually doing so? And you can also enter those in the chat function. You can put them in the questions or the chat. I know it's confusing. There's 2 separate tabs, but either one works. We'll be monitoring both.
And I think, you know, an addendum to that is for folks who have maybe tried this or had this conversation either in their communities or with their project officers, what were some of the barriers that you encountered to actually funding SSPs or elements of SSPs with using the Ryan White money?
Great. Yeah, and so we did receive a clarifying question in terms of sort of what funding. So we are talking about federal funding, particularly Ryan White funding. Yeah, if that is helpful. And from before, the comment that we received related to purchases of iPads and other supplies, that is from Wisconsin. So thank you so much, Elizabeth, for sharing that.
Amanda, Laura, this is Diana. I would say one thing that's been a bit of a challenge to using federal funding is variable guidance from project officers.
Yep. Yeah, we hear that quite a bit, I think, across a number of very complex issues, including SSPs. So we are definitely making note of that. I think that our hope with even creating this resource and producing it under a cooperative agreement with HRSA was to develop some kind of common language and understanding around this topic. And so it would be great to be able to use this as sort of the basis in which we, you know, we or you all provide this to your project officers and undergo these conversations. But I think if we're continuing to hear some confusion or key questions, it would be great for us to be aware of that so that we can continue that conversation with HRSA. Maybe even it could be something that we could, you know, provide training or additional support to project officers around, or just get clarity around, because I think even in the process of producing the fact sheet that we did, we definitely encountered some areas of discussion, we'll say, between things that we understood, things that we had heard from project officers, and things that the HRSA staff we were worked with who reviewed this resource provided guidance on.
Yeah, and I appreciate that, Diana, because really, I mean, you know, when we thought of this document in its origins, we really thought of this as being, you know, having a utility in a bi-directional manner, both about unifying that message for project officers and then also kind of creating some space for ideas that, you know, HRSA has signed off on as being eligible use of those funds. And like Amanda said, you know, if there is if folks keep hearing, you know, questions from HRSA or from other agencies, you know, definitely keep us in the loop about that, because, you know, we do have an opportunity there to think about what other types of training would look like, or what types of discussions need to happen to make sure that everyone's on the same page.
Great. Thank you. And we did also receive a comment from Holly in Iowa that there was no option for NA, so apologies for that. But in Iowa, it sounds like it is prohibited due to state law specifically. So I think that that will definitely be a challenge for some jurisdictions that we well understand. I think that's some of the policy implications that we wanted to be sure to highlight for folks, is that it does need to be allowable.
Right. And just to kind of jump off that, so state law is one, you know, requirement to use federal funds, but also, you know, local ordinance is widely being allowed as well. So like an example, Florida is an example of a place where an SSP operates in Miami, but state law does not well, they actually just passed that legislation, but up until just last month, that state law doesn't allow for SSPs broadly. Like I said, that just changed. So we also see, so you're allowed to use, if there's a local ordinance and you're in compliance with state or local law, then you are allowed to use federal funds. Another good example would be a couple of jurisdictions in Missouri.
Well, yeah, I mean, Holly, if you want to provide additional detail, if your state law specifically prohibits how the funds themselves are, the state funds or anything that you have that are used, that might also have additional clarity. But
and I think, if there is an opportunity for a local ordinance to examine, say if you had in a specific town that has a local ordinance that allows for syringe services programs, then you could consider funneling your federal money down, like pass through into your state, into your county health departments and through that way.
Oh, okay. Great. Are there any other sort of challenges or asks of us here at NASTAD or other peers that would be helpful for us to make note of moving forward? Okay. All right. Well, hearing and seeing none, I will say. I want to thank our speakers today for joining us. Thank you so much to the staff from Utah and Virginia. I think this was really helpful to provide some context and some real world examples for how this can actually be operationalized. And thank you to everyone who joined us today to participate in today's webinar. Again, as a reminder, after today, we will be sending out a follow-up memo to our Part B ADAP listserv that provides copies of the slides and webinar that will also be posted to our website, so you can find them there. And within that, we will also include a link to the evaluation to be used for today's webinar so that we can assess how well we did, hopefully, and also for us to hopefully highlight some specific activities that we can do moving forward. And if you have any other questions, concerns, or suggestions for us, please feel free to follow up with us directly. We will have accurate email addresses included in the final slides and in that memo. So please feel free to follow up from there. And thank you again, everyone, and please enjoy the rest of your afternoon.